Pat had a heart problem, and the doctor recommended that she have an implant. And the surgery in and of itself went fine, but the tenderness from that surgery never went away. And she had trouble getting people's attention.
She was pushed back from whatever the medical providers were, whether it was an inquiry at the customer desk or her post-surgical follow-up with her surgeon. They denied that there was anything wrong and that this was standard operating procedure. This is just how your body will heal.
Nobody thought it was out of normal until she became very ill. Ultimately to the point where it drove her to the emergency room.
And I'll never forget, the night we brought her into the ER in so much pain. And she was explaining to the ER nurse that she had this implant. And he's going, I don't see anything in here about an implant. I don't know. And she's going, are you kidding me? It was just down the hall 4 months ago. This same hospital. And you can't find that in my chart?
And they let her go. And it was a couple days later that they realized that she needed to come back in and that she was experiencing, I believe, what we knew at the time, septic shock.
The implant was just full of infection. When they pulled the wires out of her heart, it actually left infectious debris in her heart, which traveled to her lungs. She was in and out of the ICU 2 or maybe even 3 times in 7 weeks in the hospital.
We had the pulmonology team, the cardiology team, the infectious disease, nephrology. The nephrology team is looking out for her kidneys, but ultimately her heart was what the problem was. How was she gonna survive sepsis with a weak heart? That was never addressed.
I believe there was a lot of confusion. Things were changing so rapidly, and there were so many medical professionals involved. You need to have effective communication between family, patient, and staff. To have a printout of a pulmonologist's perspective or have a printout of what tests were done for Pat today would have been tremendous. Looking back, it's just shocking that she's not with us any longer. I think that's the hardest thing to come to terms with.
I made several attempts in order to obtain medical record. I'm not convinced to this day that I actually have complete medical record. In having others review the record, they were able to confirm that there were many components that were missing. That makes me wonder, what were you treating her for? What were you, looking at? I'm not sure. A lot of not sures.
The medical records are vague. All those phone calls, never a part of the medical records. The discussion with the technician, not part of the medical records. The discussion with the nurse practitioner or physician's assistant in the lobby of the surgeon's office, no record.
The reality is, medicine is a practice, and it's something we're practicing every day. And so we have to make sure that when we are practicing medicine, that we're working in the best interest of the client. We also got to make sure that when we're accessing medical care, we just don't rely upon our doctors. We got to look at it from multiple different lenses and multiple different perspectives. We have to ask the hard questions. We have to challenge them.
Her whole life, my mom was a fighter. She never gave up. She overcame many odds. And during her illness, she fought so hard. Her struggle and her fight and her ultimate death can't be for nothing.
Hi, everyone. I'm Donna Prosser, Chief Clinical Officer at the Patient Safety Movement Foundation. Pat Denton's story is all too common here in the United States and throughout the world. Every day, well-meaning healthcare professionals go to work and strive to provide excellent care. But when that work is happening in a disjointed, fragmented system, patients can easily fall through the cracks. And as we just heard, that can be devastating for patients and their families. At the Patient Safety Movement Foundation, we believe that we'll never eliminate preventable harm until we address these system issues. We think that every healthcare organization should be as highly reliable as other high-risk industries, like aviation, nuclear power. So in this next segment, our panel will discuss what healthcare professionals can do to advance the safety and reliability of the systems they work in and the role they play in keeping patients safe. It is now my pleasure to introduce to you the moderator for this panel, Dr. Peter Lachman. A pediatrician by background, Peter is an international leader in quality and safety. He served as CEO of ISQA, the International Society for Quality in Healthcare, from 2016 until earlier this year. And during that time, he led their transformation into one of the leading global organizations in quality, safety, and person-centered care. Currently, he's lead faculty for quality improvement at the Royal College of Physicians of Ireland in Dublin, where he directs the Leadership and Quality Program to develop clinical leaders in quality improvement. Peter, thank you so much for being with us today. We're really looking forward to this exciting panel discussion. So I will hand it over to you to introduce our esteemed panelists and get us started.
Thanks very much. Thanks, Donna, for that and for sharing the video with us, which sets the scene for what we're going to talk about today. And I'm Peter Lachman. I'm a former CEO of ISQA and now lead for quality safety teaching at the Royal College of Physicians in Dublin, in Ireland. And I've got a really great panel here with you, and I'm going to ask them to introduce themselves. I'll start with Charlene. Hi, Charlene.
Morning, Peter, and good day, everyone. My name is Charlene Hope, and I'm the Chief Pharmacy Quality and Medication Safety Officer here at University of Chicago in Chicago, Illinois.
That's great. And over to Nawa. Hi. You're coming from far away.
Hey, Peter. Yeah, I'm the furthest away. I'm talking to you from Riyadh, Saudi Arabia, where I work in King Faisal Specialist Hospital as a patient safety professional. My clinical background is in respiratory care, and my position is in patient safety, and I get to volunteer with the Patient Safety Movement Foundation as a Saudi ambassador.
That's great. Well, welcome, and I'm pleased you're with us. And then we have Pat's son, Chris. Hi.
Hello. My name is Chris. I am Pat's son. You saw the video of. It's a pleasure to be here today. I'm a licensed professional counselor. I run a private practice here in Bend, Oregon, specializing in attachment and trauma pieces. It's a pleasure to be here today with Patient Safety Movement.
Thanks. How it's going to run is I'm the moderator, and we're going to answer a few questions. And this is a very important question. As you saw in the video, one of the big problems was the lack of integration of care, the lack of sharing of information, and ultimately the lack of reliability in the care that Pat received. So what we want to really explore is how can we have healthcare workers be more reliable, and what does it take to be reliable? And those are the kind of questions we are going to talk about over the next few hours, 40 minutes or so. So the first question I'm going to go is to you, Nawa, is this question of what is high reliability in the healthcare context? What does it really mean?
You know, high reliability as a concept is very simple. It's about doing the right thing to the right person at the right time, every single time, and under dynamic circumstances. And I think that's the last two pieces is the most challenging pieces, is where most healthcare systems actually fail is in doing it right every single time and coping with the dynamic circumstances. So to tell you an example of how reliable we've gotten over years is we all know the stories and the pictures about those items flying into the MRI machine, you know, how an oxygen cylinder flies into the MRI machine, how a ventilator flies into the MRI machine where someone gets harmed, unfortunately. And one of my favorite examples about high reliability is the great catches. So one of the great catches that we've had recently is when a nurse and a radiology technologist actually stopped the line when they weren't sure about a patient who came with a device, an implanted device, that they weren't completely sure about. So they ended up stopping the line, contacting the company, the manufacturer of the device, and ensuring that certain safety measures had to be taken prior to actually doing the procedure. And imagine, how did we move from not noticing something as visible as an oxygen cylinder to being able to implement safety measures around something that's implanted inside the patient? So I'd have to say that we've moved a long way, I think, but we still have ways to go.
Yeah, I mean, thanks for that story. And I'm going to just ask Charlene, you know, because being a pharmacist, I've always seen the pharmacist as the most Generally, the most reliable people, they pay attention to detail and they make sure things happen. So the medication pathway is very important because it's the WHO challenge this year on how to get reliability in medication safety. So could you give us some examples building on what Nawa said already?
Yes, happy to do that, Peter. The medication process, which just for our audience, really starts at the time where the physician decides to prescribe a medication to meet a patient's therapeutic goals, all the way to the point of dispensing, administering that medication, and the nurse or patient themselves monitoring, did we achieve our goal? Did that medication do what it was supposed to do, or is there side effects? So I'm going to speak in a hospital setting, and I'm going to use probably the example of sepsis, is really starting with the protocol, the guidelines. There's evidence-based guidelines that the team should be centering their care around. And this should involve all team members, not just the physician. So we should have nursing, pharmacy, the lab, even respiratory therapy. They should all come together to have a good understanding of what that protocol is. That's the starting point. That's what we call a system level intervention for high reliability care. The second thing then is to leverage all our great technology. We've got electronic medical records, we've got different alerts. We want to make sure that the technology is helping our team do the right thing, as Nora said earlier. Again, another system level intervention. Then this is where all individual team members now need to kind of execute the plan, right? We get our patient in and we're all following that protocol. But we know that there are things that are going to happen that we don't know are going to happen. This is where we rely on healthcare professionals to do that important task of reporting the events, those good catches that Nora talked about, so that we know how well is our system functioning. Is there any potential failures that we need to be looking out for? This is that individual accountability for high reliable care. And then the last step is, once we do have an event, all of the team coming together to say, why did that fail? Why did we have that near miss? Do we need to make a change to the protocol? Do we need to make some changes to our technology? Because we need to make sure, again, that we are doing the right thing for the right patient each and every time. And this is kind of those key elements around high reliable care.
And it's paying attention to the smallest detail. Chris, could I just come to you and say, what do people really expect when you go to a hospital? Do you expect reliability and then you don't see it? Or what's your perspective on that?
My perspective has been that things have changed, obviously, with the pandemic and COVID, but outside of even just an emergency room or hospital setting, I think when people access medicine and healthcare, they're expecting for it to work, that it is proven, it is tried, it's true, it's the reliability piece. What I find is most people have to remember it is still a practice. We are still practicing. We are still learning every single day. While we do have standards and protocols, I do believe it's also, they need to understand that we also, we need to work together. Every case is different.
Yeah, so the key thing here is, how can we make it reliable all the time? That means the person gets the care they need the first time, every time, no matter which clinical team is on. And that is, for me, reliability, as Nawa said. So a quick question is, for healthcare workers' safety, because that's another part of it. You know, we have patient safety, we also have healthcare workers' safety. Why is this reliability piece so important? Charlene, do you want to add something there to start us off?
Yeah, really, first and foremost, it starts with building strong relationships between our clinical teams, our hospital staff, and the leaders that direct a lot of our organizations. Transparency in terms of when we have an event, that everyone is kind of at the table to learn from the event that occurred, and everyone's kind of bringing in their perspectives as well. And that's definitely one component of high reliability care that that organizations need to continue to work on.
Yeah, constantly learning. Chris, what's your view on that? on the importance for healthcare workers?
I think that if the client is informed, they are understanding of what the medical procedure and what practice is, I think that it gives the client and the practitioner both confidence in the process and confidence in one another. And if we can have confidence as a clinician in the client, in the information provided, in the relationship, I think that we also are seeing the person as an individual. I think that that helps us provide quality care and ultimately limits or minimizes liability.
Yeah. So now in your example that you gave an example of people doing above what they normally do. They stopped the line. What does it take for them to stop the line? What was there something special with those two healthcare workers?
They felt empowered. I think they had the psychological safety to question the system. And that kind of builds on the safety piece for our healthcare providers, is that it has the two pieces where you have the physical safety and the psychological safety, and you feel psychologically safe to question the system and speak up for your patients. So they really felt empowered, and they felt that they would be supported because they brought up a concern regarding patient safety.
So could I just follow up on a quick question on that? Does everyone in the organization know the great work that those two did? Did there was some way that this kind of behavior was rewarded?
Absolutely. I'm glad you asked that. And you will actually find those two individuals themselves talking about it on the YouTube because we celebrated this specific, this specific great catch along with other great catches. So every quarter we celebrate great catches around the organization, where we celebrate healthcare providers who are providing, exceptional care to their patients. And in our organization, we believe that although safety is a dynamic and visible, we always believe that we need to make it visible. We need to take the effort to make it visible for everyone. So recognizing and rewarding patient healthcare providers who take the extra mile for patient safety is an essential part of the process. And as I mentioned, those healthcare providers, you'll find them on YouTube.
That's great. And actually, Donna, later on, I'll say that should be shared with everyone, because it's such a fabulous story, because it's really going to get into the next question, which is, why is it so difficult for us to have high reliability in healthcare? And Chris, just looking at that video, there were many different points I saw where opportunities were lost. Just in those 4 minutes of that video, I could start seeing where the opportunities were lost. From your perspective, could you give us some ideas of what you saw?
There are two that really stand out for me. Initially, post operation, when she was having discomfort in her chest, there was a missed opportunity there when she had accessed frontline workers and was denied care because she had an appointment later in the next week, I believe it was. That was an opportunity, I believe, in hindsight, to have discovered the sepsis before it had gotten worse. The second time was when she was cleared of sepsis. She survived sepsis, ultimately dying of a heart attack. And when they had removed her pacemaker, I believe that there was a lot of coordinated care, a lot of, whether it was electronic medical record synthesization, sorry for that term, it wasn't happening. And I think that if people took the time to just hear and understand what the complaint was or what was happening on the ground rather than a procedural standpoint, I think this could have been avoided.
So really, did anyone ask what's the matter?
They did not initially. They heard what the matter was, but they did not attend to it in a timely fashion, almost dismissing of it. And I think that there's a person-centered approach that was lost throughout that. And throughout her care, in inquiring on different components and the various medical staff coming in and out, ultimately transferring from departments, a lot of opportunity for information not being passed through appropriately.
Yeah, and then one last question I have on this, because I think the video is so powerful. I sense there's a lack of integration, not only of care, but of knowledge and knowledge sharing. Did I get the right message?
It could. When you work with, and this lends to my clinical side of pieces and having been part of coordinated care and rollout of electronic healthcare systems and what we're trying to do on a larger perspective. The technological point, we have the capability. It was just lost. We're not there yet. There's many agencies, many groups involved. Very hard to get everybody on board, even with the technological advancements we have today.
So, yeah, that's really good. So I'm going to come to you, Charlene, because part of this reliability business is how we get people to behave. And I'm just thinking, I can speak like this because I'm a physician, I'm a pediatrician, so I can talk about doctors and feel that. Why is it that doctors do not follow guidelines, do not keep to it, whereas pharmacists do? And what is it about in medical care? What do you think it is?
Yeah. Actually, I do want to make a couple of comments about the video, and a couple of things that Chris said is, number one is, I think as a healthcare professional, especially working in a hospital, we still don't have a good understanding on how complex our healthcare delivery system really is. There's still a kind of oversimplification of processes where, if there is an event, well, why didn't the person just do what they were trained to do? Or, why do we just start making what seems like a simple change, but not thinking about what some of the unintended downstream consequences of that might be? So that's one of the things. And then I think a part of that, coming back to our physicians, is when we think about the history of medicine, these were practitioners that pretty much worked by themselves, right? They did not have this team. We did not have thousands of medications and therapies to treat all these different types of disease states. So it was a very simple beginnings that over the years has become gradually more complex. The second component that I know we'll talk about a little bit more in the session is the awareness that at the end of the day, regardless of all the training that we've gone through as healthcare professionals, we are human and we are susceptible to many biases, right? And that's what lends to the nurse or the physician not really listening to patients. They are thinking about all the other things they need to do, the documentation, rounding times, discharging patients on time. It's kind of all the things the organization wants them to get done as well too. So it's really a combination of those two things that sets up for not the best environment for high reliability. Now, around prescribing, like I mentioned, we've gone from, even in the 25 years I've been a pharmacist, the amount of drugs on the market has expanded exponentially. But we need to take care of individual patients that all have individual needs. And no longer can a physician say, okay, you've got high blood pressure, well, I'm going to give you drug A. They have to now think about what the clinical parts, how's your renal function, what's your weight like, what other medications are you on? That's one component of it. The second component of it is the financial aspect. Even if the doctor decides that's the best drug for you, is that medication covered? And this is a frustration of many physicians is, if a patient can't have a formulary medicine that they can afford under their insurance plan, they have to call in for a prior authorization. They have to get special permission. And they spend hours and hours on the phones with individuals who are not clinicians to get approvals for these medications. So, I think it's less the physician being unreliable, but their physicians working in unreliable systems.
I think that's really an answer about telling about the complexity, and part of the complexity is our success, that people are living longer with more complex conditions too, and a lot of intervening. So I think that it's a strange thing that we've been successful in many things, but that's increased the complexity and causing problems. And so while you were talking there, I was just thinking about it now that in many root cause analyses, you look to see what the cause was. Is unreliability in the care often found when you look at root cause in your root cause analysis of clinical incidents?
My God, I think that's one of the things. Root cause analysis become heartbreaking because you find all of the deficiencies in the system during the root cause process. And the thing about healthcare is that we've made processes of different layers, you know. All of those layers are there for a reason. So when Charlene is talking about prescribing, verification, preparation, dispensing by the pharmacist, then administration by the nurse, there are multiple checkpoints there. So when you have a medication error, for example, what it means that the error actually went through all of those layers, and we failed the patient in each and every layer. But how did that happen? Often it's not something related, like if it's a medication error, often it's not necessarily related to the medication itself. Sometimes it's related to, to workload. Sometimes it's related to a human error. Sometimes it's related to sound-alike, look-alike medications. So often the process of root cause analysis really bears the system in front of you and differentiates between this individual accountability and the system accountability. And really the main focus is to try and focus on how to fix the system rather than just simply focusing on individuals. And if we fix the system, then we can fix it for the next patient.
Thanks, because that's really interesting, because it's going to lead on to my next question, was going to back to Charlene and then Chris, is Charlene, what would it take for us to move from what is a fairly unreliable system to one that is highly reliable?
Right. I think there's three main components. The first one, and I'm going to start backwards based on Nora's comment, which is ensuring that we have strong learning systems, right? Chris spoke to this. We are all in the practice of medicine, and doing a root cause analysis, having a debriefing with a team, even proactively reviewing a process, what we call an FMEA. And I know we're not supposed to use abbreviations, but it is healthcare. These are all ways that we learn from our systems and how we can continually improve. And that really requires leaders like Nor, myself, Chris, and we're really looking at how do we incorporate patients into these processes so that we're engaging our patients in this learning system process, because they are very much a part of the healthcare team. The second one is that culture. We need to have a culture where all healthcare professionals want to speak up. They want to report events and know that they're not going to be punished for it, right? In healthcare, we still have this culture that every healthcare professional needs to be perfect. They're not supposed to make any errors. But in those failures, we are learning. And so we need the leaders of our organizations to support this learning environment with a culture that supports not only our providers, but also our patients to speak up when something doesn't quite look right. And then the last part of that is leadership. Those teams can't function unless the leaders are helping to create an environment for high reliability care to occur.
There are many ideas that have come out of there, of this idea of what we need. And I'm going to hone in on this idea of culture and psychological safety. Chris, what do you think about that from your perspective?
Well, my brain immediately goes to more of a holistic approach to care. A lot of the times, not just client safety or patient safety, but family safety and knowledge and understanding. I think it goes right back to informed consent and understanding what the procedure is, the best procedure, what the options are, but also the clinician or the client and the family, the patient and the family being able to communicate with the doctors on what are the overarching factors that may be influencing recovery and health and impacting and exacerbating systems. I encourage people to look to the adverse childhood experience, the ACE study, and how the psychological well-being and adverse experiences and trauma throughout lifespan can impact the physical health of pieces, and how those two may be intertwined. So I think we need to be asking all of the questions and looking at it from a very comprehensive and holistic perspective.
And Narwa, the psychological safety, you've given us a fantastic example of that already. What have you been doing in your hospital to engender that psychological safety? What's the magic?
Well, first of all, thank the messenger. I think that's a big part of it. So we have what we call the remodel for managing near misses, which is recognize, report, review, and revise. And the recognition part is both for, for incidents, but also applying the recognition to the healthcare providers. So we've hardwired this within the organization. In addition to that, we are in the middle of our Just Culture journey. So we've applied the Just Culture algorithm, and we've done a really huge education efforts around this to basically inform people that Just Culture is for them to differentiate between the system accountability and the individual accountability. This is in addition to a very strong root cause analysis program that's led by an executive sponsor. So we've engaged leadership in multiple processes. The newest thing is I'm working personally on our basically support program, emotional support program for healthcare providers who undergo basically the serious safety events, because they can have a really taxing effect on healthcare providers who are well-intended, but unfortunately are sometimes put in situations where a patient is harmed. So we're doing all of those efforts in addition to very strong management support to speaking up within the organization.
And are any of you doing what they call the safety two, is learning from what works really well? So not only learning from what doesn't work?
Yes, correct. Yeah, I think there are some efforts around basically sharing experiences between units. You know, what works well in this unit versus this unit. So imagine an operating room where they have multiple incidents of pressure injury. Then we sit both areas together and they compare practices. That's something that we do in multiple areas, but focused on a specific type of harm or a specific type of safety issue.
Well, that's great. So now we're on the home run, looking at the blue sky. Where do we go? How are we going to go? So each of you are going to have a chance to tell me how are we going to go forward, and what do we have to do so those who are watching can get a message of what they can do next. So I'm going to start with Chris on this one. What do you think we need to do, Chris, to go to the next level?
Coordinate, communicate. Look at a person-centered approach. Talk to, pay attention to what the clients are saying. Coordinate with your peers if you're a clinician. Appropriate staffing. I think education, and educating the public about what healthcare is and what it means to access healthcare is going to work for client safety as well as for clinician safety.
Yeah, that's great. Coordination and education. Charlene, how should we deal with this complexity that you've described?
I definitely agree with Chris. When we've got really complex processes, we need the entire team involved. And, one of the things that the public may not know is, all of us train in our respective professional practices separately. So pharmacist goes through their pharmacy program, medicine goes through their pharmacy program, nursing goes through theirs, respiratory therapy, our psychology therapy teams, we all train separately. But then we have to come into this big ecosystem and work together. And so I would say that one key thing is that we have to look at how we're educating professionals and how do we have some of our professional programs train teams together. This is definitely something that I've always promoted is, I'd love organizations to have, team coaches as a part of our healthcare team to help us work together as teams. That communication is always one of the number one findings from root cause analysis as the reason why events occur. And so we still need to work on that interprofessional team building. And I think that's one of the main things I would look for in the blue sky.
Mm-hmm. I really like this idea of interprofessionalism. So the professions are not working separately, but are working together to a common goal. And by doing that, they communicate. And that requires both education, because coordination is not just going to happen. You need people to understand its importance. So I'm going to come to now. I'll ask you about system accountability versus individual accountability. Where do you see the balance lies there?
I have to think that we have to really understand what happens. We have to start with inappropriate acts and then go and understand that individual failures happen often as a part of a bigger system failure. So although sometimes healthcare providers fall into incompliance, for example, but often that's a part of a bigger culture, which culture is a system failure. If it's related to culture, then culture is a system. So I see it's actually with time, understanding further more about our systems and understanding more about system accountability. And the more we understand system accountability, the more we create processes that account for that, and robust processes that account also for the fact that human beings will make mistakes. We will make mistakes. So we better recognize that and understand that we need to make those systems more robust and more strong to catch us in doing those mistakes and compensate for our inherited deficiencies. So I think overall, I think we're going to go to a stronger system where we understand further, and that can only be accomplished with leadership engagement and commitment, as well as full understanding from the entire organization of how errors happen.
Yeah, and I really like taking the systems approach that Pascal Carrion does in the SEEPS model, in which you look at the work system. How does the work system work from not only a physical point of view, also from a psychosocial point of view? So I'm coming to Chris on this one, is how can we get, from a psychosocial point of view, get people to feel safe, both the patient and the provider?
I go back to that word informed consent. I work too often with clients where they have had years upon therapy and they don't know what they were doing or why they were doing it or what procedure was used and why. I think, well, that is a missed opportunity, and sometimes they have been decades struggling with the same problem. So again, educating the client, letting them know that they really are their first line of defense in identifying what is happening, what is going on. An x-ray is great, but we don't always have that also for the mind, which is at play for some pieces. So looking at that from a biopsychosocial model, I think is very important in the coordination of multiple disciplines, which I believe, which was communicated here. Even this meeting here is a reminder of me today on some of the things that I need to make sure that I'm doing today and better in the long run for my clients. So it's always looking at it from that person-centered approach. And if we know what we're doing for our clients is the right thing, and we've got the time that we can dedicate to them and working with them, I think that makes us more confident in the process overall.
And so that leads us to my final query about the psychological safety, because what we want to do is make patients feel safe, but we also want healthcare workers to be safe. And this is coming right from the start, this theme of psychological safety. Charlene, your thoughts on that, and over to you now after Charlene.
Yeah. I was just thinking of an example recently. My sister went to the doctor, and she was talking about a medication she was going to prescribe to her. And asked my sister, well, what questions do you have for me? And she paused, asked her again. And then she said, well, if I were you, here's one of the questions you should have asked me, right? We have to continue to engage patients and inviting them to ask questions and to gain information where we are respecting the patients and in keeping their dignity intact as well too. And I just thought that was a wonderful way for the physician to engage my sister saying, yes, you should have questions for me. Here's one to get you started that you should have asked me and let me continue to tell you more. Just really smart. You know, patients and family members, you know, again, back to this history of medicine, we went to the physician with a problem, they gave us an answer, and there was not an engagement back and forth, right? This doctor knows what's wrong with me. We fully put trust in them, but we have to help our patients understand that it's no longer this paternalistic approach. It's a team coaching approach. That physician is your coach, because at the end of the day, we have to make the decisions about our healthcare, whether we're going to take the medicine, not take the medicine, can we afford it, not afford it. So we have to help our patients along in that manner as well too, and that it's really a team that's helping that patient and not just our physician. He or she. They're leading the team, right, and helping that patient's care, but everyone needs to be actively involved.
And Nawa, what do you think? Just briefly, quickly, as we come into the end.
You know, I'd have to agree with both of my colleagues there. It's, great communication is key to take us forward. Also, understanding that we have limitations and challenges in healthcare, and we may have to leverage some innovation and creativity along the process and challenge existing things, challenge existing processes.
That's great. And I just want to add something from Charlene's talking is when I was a young, newly appointed attending, I used to see parents with children with complex conditions, and the social worker used to sit in with me and she would say, "Doctor, what did you really mean?" And she would ask those questions to prompt the parents to do so, to make sure we're all on the same page. So it took me back many years listening to you, Charlene. So we're coming to the end of this fantastic last 35, 40 minutes. It's really gone sped by. So one last comment from each of you, and that'll get us to the hour. Okay, over to you. I'm going to start off with Chris.
I'd have to say self-care. If what we can do best for our clients and best for ourselves as clinicians is good, appropriate self-care.
That's great. Over to you, Charlene.
It's all about building relationships with our patients, relationships with each healthcare professional, building relationships with our leaderships that run our organizations.
That's great. Relationships, self-care, and Nawa?
I'd say safety is a dynamic and visible. It's time to make it visible.
Yeah, no, okay, so we've got a minute to go, and I'm just going to just add my bit now. I think that I've learned so much from the perspective of the therapist, Chris, also not only the son of someone who had a mishap, but really taking this perspective of saying, well, we need to think about the people who are in this relationship, the doctors, the nurses, the patient, and their psychosocial well-being as well as their physical well-being. From Charlene looking at the systems that we need to look at and how we can look at complexity and try to understand the complexity and constantly working as a team. And from Nawa, to me, I'm going to take home those two. I'm going to watch that YouTube of seeing how you can make the environment where people feel safe enough to be able to stop the line and to ask the questions. Because when I go back to that video, if there was someone who could have done that at any point in time, Chris, there may have been a different outcome. Someone stopping and saying, hang on a sec, we have to think what we are doing. So this has been really a great learning opportunity for everyone. And I want to thank all of you for your wisdom and for sharing all your experience with the people who are going to be watching this over the few days that it's beyond. So thanks very much. And I'd like to thank all of you again. Thank you.